Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle.
Welcome to The Physician's Guide to Doctoring. I am a guest host for today, Dr. Junaid Niazi. I am a MedPeds primary care doc in Minneapolis, Minnesota. I'm also a physician coach and help other physicians and APPs get their work done at work so they can reclaim their time at home for themselves. I will be hosting a free training at the end of the month, January 30th. That's a Thursday at 7 p.m. Central. It's called Leave Your Work at Work. It's where I go over my 4-step framework that really enabled me to start leaving my work at work. And so now I like to help other clinicians do the same. You can sign up for that at www.leaveyourworkatwork.com. I'd like to give a big shout out here to our guest today, Dr. Samantha. I'm going to let Samantha introduce herself because this is actually our first time meeting. Dr. Block thought it would be interesting to try this again. We did this back a couple of months ago where I brought somebody on and sort of coached them through their clinic day, and he thought it might be interesting to try it again. And so I reached out to my Facebook group called Stop Charting at Home and just asked if anybody would be available today to do it. And she bravely raised her hand and we were able to make it happen. So welcome, Dr. Exler, if you don't mind introducing yourself briefly.
Yes, thank you, Junaid. So I am originally from Chicago suburbs, and I went to college in Boston and settled down in North Carolina after that for my medical training. I went to Wake Forest for medical school in Winston-Salem, and then Duke for my family medicine residency. And following that, I did about a year at a private practice that was integrative medicine. I don't have training in complementary and alternative medicine, but I'm very open-minded to the approach of meeting patients to where they are. So that was a good temporary fit, but our family ended up moving to Greensboro, which is just about an hour away, closer to Winston-Salem. And I ended up being back with Wake Forest, which is now Atrium Health, Wake Forest Baptist Medical Center. And I'm out in Summerfield, North Carolina at an outpatient family medicine, semi-rural, semi-suburban clinic, seeing mostly adults, but also babies and children, not doing any prenatal care. I love the office. I was attracted to it because it felt right. It felt like how family medicine should be. It's not the prettiest building. At first, there weren't as many resources in terms of specialists, but a lot of people have been working there for years. And so they treat each other like family. I've known the patients for a long time too. So it's just a really great, well-rounded exposure to a patient population. I love it so much because it's everything that I'm looking for in terms of having the support of an academic medical center and their specialists somewhat nearby, and they're even building some stuff closer to us, while also maintaining a lot of independence with some patients who don't want to travel to specialists and want us to do, the procedures on them or manage their complicated conditions. And I've got a mix of patients from, farmers, or we see a lot of the medical professionals too, because of their insurance, and then typical suburbians. And I couldn't ask for anything better. And the people there and the patients, except for time. I wish I had more time. And that's always been my issue since I started medical school. And I kept thinking I would get better at it, more efficient. And surprised I haven't. And so I am hanging on by a thread. My patients feel like they get great care. I feel like I give them great care, but it's coming at a really big cost to the staff at my clinic because they're having to, support me in ways with me running behind on things, front desk too. And then a big price to my family. I have 4 and a 6-year-old. And then my own health, which I've never gotten around to taking care of because we keep putting that off too. So I've been looking at coaching actively recently, and this just jumped out at me at the exact right moment. And I was really excited to take you up on this.
Yeah. Well, our kids are the exact same age.
Oh,
4 and
wow.
a
Yeah.
6-year-old.
So
That's pretty interesting. Yeah. And, don't I think a lot of people, one thing I've seen in folks that I've coached is that they think this problem is unique to them.
it's hard not to feel that way until you talk to other people.
And it's not something you want to talk about really, right? So a lot of physicians will talk
Right.
about, oh, we're busy or the system is terrible and it doesn't set us up for success. And I had to spend my whole day doing X, Y, or Z and prior auths and blah, blah, blah. But rarely do we make that jump to and it is really impacting my life. It is really keeping me from living the life I want, enjoying the practice of medicine. And we're seeing the repercussions of that. People
Mhm.
are scaling back hours. But my clinic, I mentioned I'm med peds. We have family practice and internal medicine as well. And I think there's 17 or 18 of us, and only one of us is full time, like 1.0.
Wow.
And they say that almost as if it's like, oh, look how flexible we are. And I'm like, that's actually more of an indictment on the system that
Mhm.
in this day and age, it's hard to work 1.0 hours because of all the extra work you have to do that, cutting back to point 0.7 or point 0.8 is generally working still more than 40 hours a week. So yeah, I'm happy that you're opening up and being vulnerable about this. It's the only way that we can actually sort of make improvements and make some changes. What do you think is one area you'd like to get coached on or that you're really struggling with?
So I actually read a transcript last night of another podcast that you were a guest on, and I resonated with a lot of the things you talked about because there were a lot of practical things that are 100% true that I could be doing differently and that I need help with. And I need to be held accountable for being intentional about making those changes. But I think you really pointed to the big thing behind it all, which is what's driving this behavior that's preventing me from making changes to my habits. And that's that type A perfectionism, wanting to be thorough, wanting to give the best care possible, overthinking everything, wanting to make sure I document it all, spending all the time with the patient, but then needing to spend time documenting that I spent that time and worried about, you know, making mistakes, basically to the point where it all gets in the way of me being able to follow through with delivering the complete care. So I think if, at least I'm further in my practice now where I have the confidence of my medical knowledge, but I've always been very aware and excited about the fact that this is going to be a career of lifelong learning.
Mhm.
And I love trying to stay up to date. Everything changes so quickly and it's really important. And like I said, I have a lot of patients who want me to manage as much as I can. So I'm at the point now where partially being okay with drawing lines about what is my role, where can I draw that line? So I guess specifically, I'll say this. One of the things is my notes is too thorough, right?
Mhm.
And I spend too long on them. I want them to be beautiful, which is pointless, right? I mean, it's not pointless, but I'm supposed to think it's pointless. And I have trouble not interacting with my patient in a very personal way with eye
Mhm.
contact. Yeah, I can type really well looking at them. And I have started using an AI program, which has been really helpful at
Good.
capturing the conversation without, putting in non-relevant or intimate things that they're saying. But I notice myself I'm still not getting the typing and the clicking, all the clicking and during the visit for the orders and just my note basically. So I think dot phrases and all that would be really beneficial. There's a lot set up in the system to help us use it more efficiently, but I just don't do it. Not because I haven't had the time to set it up that way. It's
Mhm.
then actually then using it, like remembering what
Mhm.
are the dot phrases that I've made. I want to be more efficient with my note and be okay with B minus notes instead of A plus notes. I want to be okay with not having everything I want in there exactly the way I would word it and being okay with typos.
So, earlier you said something about the note being sort of perfect and that you shouldn't want it that way. And It's not necessarily a shouldn't, because whenever you start throwing shouldn'ts
Mm.
or shoulds around, there's an internal resistance that there's an ideal state and you're not living up to it. And it's almost like a declaration of like surrender to that, oh,
Mhm.
I should be doing this other thing. There's a better way to do it. When you think of what your notes are supposed to do, in my mind, it's to capture what occurred so that if they come see you the next month, you can kind of pick up where you left off.
Yes.
If they go see somebody else, they can read your note and kind of quickly figure out what's going on. And then, so that's sort of the communication aspect. Then there's obviously the billing aspect, which has gotten a lot easier since
Yeah.
the 2021 changes, which is nice. And then the last one is sort of that medical legal part
Mhm.
of it. So when you're thinking like, oh, I really want to write this beautiful, polished note, which of those three things do you think you're really trying to cater to?
Good question. I think I'm trying to cater to helping me reference it when I see them next or reference their chart again. I tend to be really, really thorough and without writing that down, like I don't remember it. Like everyone it just blends together for me. I don't know. Maybe it's all the sleep deprivation from toddler years or something, you know?
What's important is that you already said the key part. You are thorough. So you
Right.
are already thorough.
Well, sorry, I'm
R-
thorough
in-
in my information gathering.
Right, right. But so where I'm getting at with this is an issue of you've done the work.
Yeah, I don't wanna miss any of it.
But even like the next time you see the patient,
Mhm. Yeah,
you can trust that you asked certain things or did certain things, and you can reference it more generally, right? So like,
true, you're right.
so for example,
Yeah,
if I'm asking somebody about or they're coming in with abdominal pain, I used to write out, like denies dysuria, denies hematuria, denies increased frequency. Now I just say denies urinary symptoms because I trust
mhm.
that I know I've asked those questions,
That's a good way to think about it.
right?
Yeah,
And if I say they have no abdominal complaints, I trust that means I've asked them about their bowel habits, any discomfort, reflux, whatever it may be. So start bucketing things as you ask them and trust that you've done that. And it's
yeah,
okay if you have to ask the patient the same question again, because honestly, the story changes even if you ask the same question. But
true.
just because you asked it once already, it's not going to hurt if you ask it again.
I initially set up templates back when the billing was more based on needing all the components of the
Yeah.
HPI and physical exam, pertinent positives and negatives. I think now I'm trying to pull that forward so much, and that's also why I'm not transitioning to using my AI HPI more because I'm like, I worked so hard to make that beautiful thing. I need to keep using it, but I'm stuck in that way. I think you're right. The same types of diagnoses and everything. Like if they have hypothyroidism, and that's one of the chronic problems I'm following for them, I can trust that I'm going to ask them about over or underactive
Yeah.
thyroid symptoms at their visit.
Review systems. And then in your H, you can just say, I mean, if you're using an AI scribe, they are more useful for the HPI section. But if you have a really nice, so I don't use them for physicals because I have a really, my problem list on the HPI that then I use to inform my plan is too nice and too honed over the
Right.
years to
Right.
where a giant block of paragraph text would be a disservice to me and anyone trying to read it. So I don't use the AI scribe for physicals. So then I'd say, hypothyroidism, stable on current synthroid dose, no new symptom. What have I conveyed in those three sentences that are maybe 10 words total?
Basically, that they're not having any symptoms of that, and
The
you're
chronic issue and
currently
it's well
it
managed,
and it's stable, and it's chronic, yeah.
versus me being no, no cold intolerance, no heat intolerance, no
Right.
diarrhea, no constipation, no this, no, like,
Yeah,
right? If, as
yeah.
long as you are truthfully asking those questions, is it really critical that you document every single little thing that you've asked?
I don't know, not for the beautiful note part anymore necessarily. Now we get into the legal stuff.
Yeah, no, that's a great point. So legally, what I've heard is there's a phrase you're allowed to use. I'm
Mhm.
not a legal expert or a medical expert, so use at your own peril. But you are allowed to defer to your usual and customary standard of care or the way of doing things. There is precedent for being able to say, if this is in the note, this means I did these things as what I usually do. I heard that on some lawyer talking on some podcast some years ago and latched onto it.
I'm gonna latch onto that too. I'm gonna hold on to that.
But look at it the other way, right? If I write every review system question, I leave out one. Now,
Yes. Good
if
point.
I'm being deposed about it, they could say, well, you asked all these other questions that you documented. Why would you have not asked about laryngeal edema in your hypothyroid patient? That was for you, Dr. Bradley Block, for ENT complications and hypothyroidism. And, then they might have a stronger case.
That makes
Whereas
sense.
if you say, I asked my usual set of thyroid-related review of systems and I document it as such, they have less of a leg to stand on. So it sounds like, if notes are your big issue in spending time with your notes, do you write in like complete sentences? I'd have to ask.
Oh, no, that's the problem is I like the way I've made it all concise but thorough, and AI, which is really, really helpful. And I never thought it would be, because I was like, how can it possibly capture these convoluted conversations about like everything? But it does amazingly. But that makes like a paragraph. And it's not serving a good purpose for me being able to look back at my work without having to read a story, basically. But it's achieving the goal of at least putting something so that there is a note to look back at.
Right.
So
Yeah, I use it more for someone's coming in for an acute thing.
it's really good for that. Yeah. And most of my patients, most of them are not coming in for acute things. Well, they have an acute thing also, but it's usually for their chronic medical conditions, plus or minus their annual physical or medical wellness
Right.
visit. And I basically stagger those. So every 6 months is usually addressing their chronic conditions. And then one of those per year is also doing their full preventative health, and I split bill. So my templates I have are just beautiful. I don't trust anything I'm looking at in the system from other specialist notes or even like a trend of lab results, because it misses things, it pulls things.
Mm.
But if I write it in my note, I trust it. And so I want to, like, that's why.
The gospel as told by Samantha.
Yes. Like if their pap smear was this date and it was this result, I know if I wrote that, I know that that's true. So I don't want to just write pap up to date, because next time I'm just going to still have to go look and be like, well, was it? Maybe you're right. I should trust that.
But can you give, so you gave sort of maybe two extremes there, but instead of just writing pap up to date versus.
Is that extremes? Are those extremes?
Not real. I'm just using that as maybe you gave a dichotomous situation and there's an in between. So like, for example, I write pap normal done May 2023, next due 5 years. So I know that if I've written that, then I don't need to worry about that.
You're right.
Until 2028 or whatever.
You're absolutely right. I can start maybe going to the in between. And so it doesn't have to be detailed, but it could be detailed enough to give me what I need without being like every single detail ever. That makes sense.
Right. So you can capture that information. And if you're writing it so I actually write sort of their healthcare or maintenance stuff for physical in the HPI section, maybe a little atypical. And then I don't necessarily assessment and plan.
Oh, yeah, no, I do what you do.
And then in my assessment and plan, I just say like up to date or, see above for whatever. But a lot of people regurgitate the same stuff over and over and over again.
Mm-hmm.
The other thing is I write the stuff out for the patients on their after visit summary. So I'll be like, hey, you're next due for your PAP in June of 2026. So then if I can't figure it out, and if it's not clear in my note, I know I generally made it clear for the patient. So then I have that to go off of. Same with colonoscopy for their wellness visits and things like that. So see where you're putting things in the chart that you can reference. Trust yourself a little more. You may have a day where you're just swamped and you just write PAP normal for today because that's all I needed to write for today. And I know next time I see them, I might have to dig it up again and look at it, and that's okay.
I've done that sometimes just as like exposure therapy for myself, to be like, do it and be okay with it and know that the world didn't end after that.
Well, right. The world did not end if you have to look stuff up. I smiled when you mentioned I have like the best templates.
Everyone thinks that about themselves, right? Sorry.
Everyone thinks that, but everyone also thinks that that's the issue, or that's the thing. So when I first
Oh.
started, I started making all these templates, and I quickly realized that they're not that helpful.
Mm.
You need a base skeleton
Mhm.
and of a template, and then I actually use sort of modular things. So like I have, if someone's coming in for an acute issue, I just hit a new note type that's will pull in, just the different sections, but they're generally pretty blank other than a sort of templated exam. And then if they're coming in for a cough, for example, I'll do .s cough, which is subjective for cough, which will pull in my questions for that issue. If I'm seeing them for UTI, .s subjective UTI. You have to think it's something that your organization is not using so that they don't change them and you lose all yours. But then same thing for like if they're just literally coming in for a UTI, that's a pretty limited exam I'm doing. So I have .ex exam UTI, and that will even key me in like, oh yeah, don't forget to check for costovertebral
Mhm.
tenderness. Don't forget to push over their bladder, whatever it may be. Same thing for back pain, just to direct my exam and all there. And then I used to think having really detailed templates for assessment and plans was going to be super helpful. I haven't really only for diabetes. Diabetes is probably the only one where I really use because there's just so many different things to keep track of. And for other specialists, I think if they're having to track other things, think oncology, maybe rheumatology, if when was the patient's last eye exam, if they're on Plaquenil, things like that. I think it can be useful for you to track those things. But otherwise, templates tend to bring in too much extra stuff.
Yeah.
And then
Yeah, I guess
it's easier to edit down, I will say that, but you're also spending time now reading the template, trying to figure out, is it needed or not?
true,
I
true.
never pull in to my note directly lab results or radiology results.
I did stop doing that mostly. Well, I finally figured out, like, how to do the dot phrase to get only what I need if I really want it there.
Again, I'll do it in my diabetes visits for last whatever number of A1Cs or something like that, or last number of blood pressures if I need
Mhm.
that just for a quick reference. But otherwise, I will just type in whatever labs I want because not all labs are relevant.
Right, right. And
I
with the
will,
AI thing, it says it, and if I'm saying it out loud,
yeah,
it'll put it in my little results section in the objective part. It's good.
they're getting better.
But again, it's like, sometimes I'm like, "Do I trust it? Like, is that what it was?" You talked about, like, with the diabetes or, say they're on Plaquenil or, eye exam stuff, keeping track of certain things. I think that's sort of what I mean where I'm getting hung up. When I say templates, it's not really that they're really pulling in much information. It's more that I unfortunately, I feel like I'm having to keep track of a lot of the things, and maybe I shouldn't do it for that my patient isn't or their specialist isn't. So I feel like they have a lot of conditions where even when they're seeing specialists, for some reason, I'm letting myself type in there when was their last visit with them? Like, is their visit with the specialist up to date? And did the specialist make a change for that treatment? And when is the next echo due for that thing or whatever, because the specialist says it, patient doesn't schedule it, or they do, and
Mhm.
nothing happens and it just gets lost. But maybe I don't need to feel responsible for that.
I mean, I do that too, but I do that as part of usually my pre-charting right
Mhm.
before I go in. And if there's things in the note that I need to remember to address, I don't know what EHR you use, but I just leave little wild cards
Okay.
in Epic, which means it's just a thing that you can hop to with a keyboard shortcut, and it won't let you sign the chart unless you delete
Yes.
them or put something there. So I use those to sort of guide my attention strategically through the note so I can also stay on task.
That's a good idea.
But I'll pre-chart and I'll just say, okay, saw urology. They did their annual follow-up with urology. They still want to check PSAs. They still want to do this. They don't want to do that. And so, or maybe they want another CT abdomen pelvis in X number of months. But generally, I've written that before. And so I'm just updating the date.
Do you usually pre-chart, you said right before you see them?
I do it right before I see a patient.
And do you dictate?
I talk too much. Yeah, I looked. We used to use Dragon dictation, and my notes were about 40% longer
Wow, that makes
and
sense, yeah.
harder for me to find stuff because it was like full sentences
Mhm.
and that just is my personal quirk with dictating.
Okay. I think even the way you're talking about how you would say it out in your note gives me a good idea of how I'm even being unnecessarily detailed about some of those things because it might not feel like it's that big of a deal to type a date, but actually, like, it does take a few, like, seconds, and then you have to be like, "Wait, is that the it doesn't need to be the exact date." You just be like,
I do month, year, or sometimes
"Yeah,
I just do season.
yeah,
If
yeah,
cardiology wanted them to have that echo in June of 2025, I just say
right,
summer of
summer."
25
Yeah.
echo.
I think I just get bogged down in, like, it's almost like a compulsion or a habit that you just feel like you're suddenly, like, in a mindless thing that you're doing, and again, if you're not intentional, you just fall back into the same habits. So, do you have any ways that you keep yourself throughout the day, like, mindful of being like, "Oh, yeah, I'm working on trying to, do this in my new habits?"
Yeah, one of the ways I advocate folks to use, I don't use this a lot anymore, but just simple cues. So a visual cue. So the simplest one generally that I've seen or come up with is just a colored sticky note. You can write something on it or not write something on it. You know what it means. But I've even encouraged clients to put that in their exam rooms, like on their monitor.
I
And when they see the bright pink sticky note, they're like, oh yeah, I'm supposed to do, because that's the cue. So then what is the cue it's supposed to remind you of? You take the action or you do whatever, maybe the cue is, oh, I'm supposed to end 5 minutes early, or,
mm,
start summing up the visits. The patient knows it's coming to an end. Or whatever you need to work on. I found the cue system is what works best as a visual reminder.
that makes sense. I think that will work for me, even, like, a bright color or something.
You can even write yourself little encouraging notes. I mean,
I
I've had some folks that do that.
I sometimes do, but then they just, like, well, I think you're right, like, if I put them in the room instead of on my keyboard or something, then they won't just, like, wear off and disappear halfway through the day, so it's a good idea.
Right. Right. I think as we wrap up here,
Mhm.
the last thing I'll say is you said something at the beginning about you really enjoy sort of the face to face with the patient and not really turning and typing and clicking and getting the orders and all in. Have you ever tried just telling the patient, let me get these orders in before we send you off, or anything like that?
Yes.
Or give me a minute or two to just get these in, or anything like that?
Yes.
How does that feel
Occasionally.
when you do that?
Well, I feel good knowing that it will actually be done because whenever I don't do it, it doesn't get done in a timely fashion. But then I don't know, I guess I feel guilty that I'm staring at a computer. I even tell them, I'm like, just lots of clicks. Sorry, I'm staring at a computer instead of looking at you. But they don't seem to get mad. I should try it more, right?
So, from the patient's perspective, how many times do you think they've shown up to a pharmacy and not had a med that the doctor said they'd put in later? Or they show up
A
to
lot.
lab or radiology
A
and the
lot.
orders aren't there, and then now they're stuck or they're calling the office to request.
Yes.
And I think probably most patients have experienced that to some
Mm.
degree,
Yes.
right? Like even you probably, as you said, you
For
aren't
sure. Yeah.
necessarily focusing on your health, but your exposure to our healthcare system, that's probably happened.
Yeah, you're right.
So, I will say, let me get these orders in so that we don't forget, or so that when you show up to lab, they're ready to take you. And people really appreciate that.
And they do. Okay. Okay. You're
Um,
right. Because it takes away so much time from everybody else when the other way happens.
well, yeah, because then they'll call
They're
you later,
calling.
and then now you're getting interrupted, and now they're a little irate. The pharmacist might
Mhm.
not be happy. You're trying to be like, what med was I supposed to send to where? And so it's more work. The other thing is part of my pre-charting, I try to get a lot of that stuff done where I'll order all their labs and re-up their meds and just have them pended.
Okay.
And then if I need to change something, I change something.
When I do pre-chart, yeah, I do that and it helps immensely. I need to pre-chart.
Yeah, and another reason I do that is because a lot of folks will tell me they don't need refills.
Right. And they do.
And if I pre-charted, I've spent that extra second looking at like, okay, this was last filled, or I prescribed this a year ago. They're clearly due for refills, even if they think they're not.
Right.
So
Right.
I'm just going to send it in.
Yeah.
And so sometimes I'll accidentally hit sign before I walk in the room, and the patient's like, "Oh, you sent my prescriptions in already," because they got their notification from their pharmacy.
hmm
And they're like, "That's cool," and I'm like, "Oh yeah, sorry, I hit
Oops.
sign prematurely," but they at least know that I put it in.
Yeah. No, that makes sense. When I do that, it really does help. I just got to be more efficient about maybe I can focus more on that since it affects the patient more than my note does. And so when I'm pre-charting, I can prioritize that versus filling in all those little other things in my note because that's not as urgent. Yeah, I think I'm gonna do that.
I don't want you to not do your note at the expense of that. I
No,
think you
no, I mean,
get
well,
to where you do both, but if you're decreasing interruptions later on, that's a huge save in your time and your staff's time.
I think it will make a big difference because I think that's where people are starting to get more frustrated.
Yeah. And I mean, the other reason I tee that stuff up is then it's not a mental load when I'm with the patient. And
Right.
then I'm not trying to be like, "Oh, no. Oh, I misclicked." There's still some stuff that it takes time. Like, if I'm starting somebody on a GLP in
Mhm,
order, I try to send in all the prescriptions, so if it gets approved, they'll all get approved, hopefully, in a
mhm.
prior auth. And I found the only way to have the pharmacy not balk at me sending in, like, 7 prescriptions of Mounjaro at the same time is to actually have the dates. Like, you start this one on this date, 4 doses or, yeah, 4 doses, whatever, end on this date, copy that date into the next order. That's the only way I found where I don't get pushback.
Have you made smart orders with that?
I've asked that those be made, so they're under consideration because we have
They're
smart
really
orders
good.
like that for, like, Adderall. If you do,
Oh,
like,
you
a
do?
3-month
Oh,
supply of Adderall, it'll do 3 one-month prescriptions.
mhm.
So they can build it, but for the time being,
Okay.
organization's number 1 priority. No, I can't build that in myself easily. But there's things like that where it's easier to do something outside of the room.
Especially things with a lot of clicks. I feel like that's what I'm feeling
I
bad
do.
yeah, when I'm typing with the patient, I don't feel as bad and I can look at them more easily. It's all the clicks, and that's
Mhm.
usually all the orders because you have to change, like, associate it with the diagnosis and all that stuff. So I
Right.
think if I can do that outside the room, get it all done with.
Y And keyboard shortcuts are your best friend.
Oh,
So
yeah.
the less you go from your keyboard to your mouse, the faster you'll move.
Ooh, okay. I need to
Um,
figure those out.
which EHR do you
Epic.
use? So, for example, for me, I think if I hit Control O, that'll open up the little order
Mm.
thing at the bottom, and I can just
Oh.
start typing an order, and then I hit Alt Y. It'll bank the order on the one that I want. Like if there's 3 different lipid orders, and then I'll start typing A1. Like, so I don't actually leave the keyboard while I'm ordering if I can avoid doing that. And then when I'm done with that, I hit Alt, I think A, it accepts the orders, and I hit Alt X, opens up diagnosis association. And that's then when I'll go to my mouse to click.
Okay.
So
Maybe I can look into that too.
and just for the folks that are listening to this, just to point out, her EHR just came up in the last like minute of this podcast. So everything else we've talked about is really EHR agnostic. That's something people always think is, oh, I don't have the right EHR. It has to be Epic or it has to be this or that. But no, I can help her specifically with Epic just because that's what my organization uses. But a lot of what we talked about is independent of your EHR. It's about you and how you're showing up for your work. Well, Dr. Samantha, thank you so much for opening up and being vulnerable and letting me coach you through some of these things. I'm excited to see how things change for you over the upcoming weeks and months. You'll have to let us know in the Facebook group.
Oh,
Um,
absolutely. Hold me accountable, please. That's what I
w-
need.
Fair enough. Fair enough. A big shout out and thanks to Dr. Bradley Block for letting me take over the physician's guide to doctoring one more time. I think this is my 3rd or 4th podcast recording for him. And I will be hosting that free live training on Thursday, January 30th at 7 p.m. Central called Leave Your Work at Work. If you're struggling with this stuff, come to the training. It's free and we will try to get you on the right footing for 2025. And you can register for that at www.leaveyourworkatwork.com. All right. Thanks, everybody.
Thank you.
Thanks for listening. So please share it, or like it, or comment on a social media post, or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.